Hello friends, this is Nishant Gautam, Associate Professor from the Department of Pharmacology, Laureate Institute of Pharmacy. We already discussed about the topic diuretics in previous three parts. Today we will discuss the remaining portion of diuretics in its last fourth parts. Let us start the remaining description of the diuretics. The next class of diuretics is carbonic anhydrase inhibitors. The acetazolamide belongs to this class of diuretics. So let us know about the carbonic anhydrase inhibitors. The carbonic anhydrase is an enzyme which catalyzes the reversible reaction of water and carbon dioxide and forms the carbonic acid. This carbonic acid spontaneously ionizes to the hydrogen ion and HCO3 negative. The carbonic anhydrase thus functions in carbon dioxide and HCO3 negative transport and in the hydrogen ion secretion. The enzyme is present in renal tubular cell, especially in proximal tubule, gastric mucosa, exocrine pancreas, ciliary body of eyes, brain and RBCs. In these tissues, a gross excess of carbonic anhydrase is present. More than 99% inhibition is required to produce the effect. The action of this carbonic anhydrase inhibitor at the different side of this nephron can be understood with the help of this diagram. In this diagram, the site 1, site 4 showing the activity of the carbonic anhydrase inhibitor on this transportation of the hydrogen ion with the antipode system with that of the sodium, so that it acts as a anti-diuretic. Another thing, we can understand the formation of the carbonic acid and the transportation of the hydrogen ion with that of the sodium hydrogen antipode. How it is transporting, which we can understand by this second diagram. Here in this, the sodium hydrogen antipode is there, and this is the carbonic anhydrase at the proximal tubule cell and at the luminal area. At both the area, it is showing the reversible reaction with that of the water and the carbon dioxide. Actually, the exchange with hydrogen ion in the proximal tubule cells takes place with the secreted hydrogen ion with the help of a sodium hydrogen antipode. Also, we can say sodium hydrogen exchanger located at the luminal membrane. This exchange moves the sodium from tubular fluid to inside the cell. The secreted hydrogen ion combines with that of the HCO3 negative in the tubular fluid to form the carbonic acid. This carbonic acid is broken into the water and carbon dioxide by the membrane bound brush bordered carbonic anhydrase, that is the type 4 enzyme. Because spontaneous dissociation of carbonic acid is very slow, so both carbon dioxide and water diffuse inside the cell and recombine to form the carbonic acid. At the intracellular soluble type, the second carbonic anhydrase catalyzes the reaction, which is the source of hydrogen ion. The dissociated HCO3 negative in the cell is transported to cortical extracellular fluid by basolateral membrane, where the Na plus HCO3 negative symporter resulting in net reabsorption of NaHCO3. Particularly, all HCO3 negative is reabsorbed in proximal tubule by this mechanism, because tubular membrane as such is relatively impermeable to HCO3 negative. Now come to the description and the action of acetazolamide. Acetazolamide is a sulfonamide derivative which non-competitively but reversibly inhibit the carbonic anhydrase type 2 in proximal tubule cell, resulting in slowing of hydration of the carbon dioxide, so that there is a decreased availability of the hydrogen ion to exchange with that of the luminal sodium through the sodium hydrogen antipoter. The inhibition of brush border carbonic anhydrase type 4 retards the dehydration of H2CO3 in the tubular fluid, so that less carbon dioxide diffuses back into the cell. The net effect is the inhibition of HCO3 negative and accompanying the sodium for the reabsorption in the proximal tubule. However, the resulting alkaline diuresis is only mild, that is, maximal fraction of the sodium loss up to the 5%. Because the part of the sodium but not HCO3 negative rejected in the proximal tubule is reabsorbed at the high capacity at the ascending limb of lobe of the anhydrase. Further, the secretion of hydrogen ion in distal tubule and collecting duct is also interfered. Though hydrogen ion is secreted at this site by a H plus ATPase, it is generated in the cell by the carbonic anhydrase mediated reactions. As such, this is a subsidiary site of the action of carbonic anhydrase inhibitors, that is site 4. Further, this is the sodium hydrogen antipoter, and the secretion of H plus in distal tubule and collecting duct is also interfered, as we discussed, and responsible for the Mark-Kaliuresis is the mechanism of action of acetazolamide, and this is how the acetazolamide shows its diuretic action. Now, let us discuss about the therapeutic uses and the adverse effects of acetazolamide. Let us start with the therapeutic uses of the acetazolamide. The therapeutic use of the acetazolamide is to treat the glaucoma as an adjunct with that of the other ocular hypertensives, and to treat the acute mountain sickness. In this case, it is used for the symptomatic relief as well as a prophylaxis. The benefit occurs probably due to reduced cerebrospinal fluid formation as well as lowering of the CSF and the brain pH. The other therapeutic uses of acetazolamide is to treat the periodic paralysis. Also, it is used for the alkalized urine. It is also used to treat the epilepsy as an adjuvant in the absence seizures when primary drugs are not fully effective. Then come to the next point, that is the adverse effects of acetazolamide. The acidosis is the major adverse effect of acetazolamide. Then hypokalemia, drowsiness, paresthesis, fatigue, abdominal discomfort, hypersensitivity reactions, and also it shows the bone marrow depression, but it is very rare. Then the other is the contraindication in the liver disease. Here it potentiate to induce the hepatic coma also. Then the third class of the diuretics as a adjunctive diuretic is the potassium sparing diuretics. Actually, the potassium sparing diuretics is further categorized into the two aldosterone antagonist and renal epithelial sodium channel inhibitors. This aldosterone antagonist and renal epithelial sodium channel inhibitors indirectly conserve the potassium while inducing mild natriuresis and are called as the potassium sparing diuretics. So let us discuss one by one the first category of potassium sparing diuretics, aldosterone antagonist, that is the spironolactone. The potassium sparing diuretics at the late distal tubule and the collecting duct cell can be easily understand the mechanism of action with the help of this diagram. Actually, what happens? The secretion of aldosterone is responsible for the formation of aldosterone binding with that of the mineralocorticoid receptor. But the action of spironolactone is that it antagonizes the mineralocorticoid receptor. So there is the failure of the formation of the complex of mineralocorticoid receptor with that of the aldosterone. So what happens here? To understand the full mechanism of action of spironolactone, we have to go through the normal physiology of this cell. So at this site, and the mechanism of action of potassium sparing diuretics on the late distal tubule and collecting duct cell can be understood as when the aldosterone penetrates the cell from the interstitial side and combines with that of the mineralocorticoid receptor. Then the complex translocate to the nucleus, where it promotes the gene-mediated mRNA synthesis. And the mRNA then directs the synthesis of aldosterone-induced protein, that is denoted as AIPs here in this diagram. This aldosterone-induced protein AIPs include the sodium-potassium ATPase. See here in this diagram how it is included. And the renal epithelial amiloride sensitive sodium channel, both is there in this diagram, is including by the aldosterone induced protein. More of these proteins are synthesized. The aldosterone induced protein also activate these sodium channels and translocate them from cytosolic side to the luminal membrane. They also translocate the sodium potassium ATPase to the basolateral membrane. The aldosterone induced proteins also increases the ATP production by the mitochondria. So all these changes promote the sodium reabsorption. So what happens? More potassium and hydrogen is secreted indirectly. Thus, spironolactone get bind to the mineralocorticoid receptor and prevents the aldosterone action and produces the opposite effect. In this manner, it is showing its potassium sparing diuretic effect. Let us discuss a summarized mechanism. The spironolactone and epinol blocks the aldosterone activity by blocking the mineralocorticoid receptor. Aldosterone induced protein sodium channel not expressed. So there is a decrease in the absorption of sodium and the water. This is how it is showing the antidiuretic effect. Then it acts from the interstitial side. You see in this diagram, it is acting from the interstitial side. Also, the very important point over here, no aldosterone and no effect will be there. Then the second category of the potassium sparing diuretic is the inhibitors of renal epithelial sodium channels, that is the amiloride. This potassium sparing diuretics on the late distal tubule collecting duct, showing its mechanism and how it is showing its potassium sparing diuretic effect, we can understand very easily with the help of this diagram. Here, see in this diagram, this one is the amiloride and it is inhibiting the amiloride sensitive sodium channel which is present at the luminal site. Actually, this amiloride approaches the sodium channel from the luminal side and blocks it. So, reducing the lumen negative transepithelial potential difference, which is governs the potassium and hydrogen ion secretion. Now, let us know something about the class of the drug, that is the tryptophan and amiloride. Both are the non-steroidal organic bases with identical action. The most important effect is to decrease the potassium excretion, particularly when it is high due to large potassium intake or use of a diuretic that enhances the potassium loss. This is accompanied by a small increase in the sodium excretion. The excess urinary sodium is matched by the chloride and variable amounts of the HCO3 negative. So, urine is slightly alkalized. The direct effect on urinary electrolyte pattern is superficially similar to the spironolactone, but their action is independent of aldosterone. Here they are independent with the action of aldosterone. Without that, they are showing the potassium sparing diuresis effect by the inhibition of only renal epithelial sodium channel. So that also the calcium and magnesium excretion is also reduced, but there is no effect on renal hemodynamics. So let us summarize the mechanism of action of the amiloride. The amiloride sensitive sodium channel at the distal tubule and collecting duct. Here, entry of the sodium ion is blocked at the transepithelial potential is not generated. So the excretion of potassium is decreased. This is how the amiloride is showing the potassium sparing diuresis. Then, due to decreased transepithelial potassium, the hydrogen ion secretion via hydrogen ion ATPase pump is decreased. It is showing the predisposes to the acidosis. Now, let us discuss the therapeutic use of aldosterone antagonist, that is the spironolactone. It is an aldosterone antagonist which is therapeutically used as an adjunctive with that of the high efficacy diuretics and the medium efficacy diuretics. It is itself showing the weak diuretic effect. So always used in the combination of the further two classes of the diuretics, that is the high efficacy diuretics and the medium efficacy diuretics. It is used to treat the edema. It is more useful in cirrhotic and nephrotic edema, in which aldosterone levels are generally high. Spironolactone is frequently added to a thiazide or loop diuretic in the treatment of ascites due to the cirrhosis of liver. It breaks the resistance to thiazide diuretics that develops due to secondary hyperaldosteronism, and it responds well in such conditions. Thus, it is particularly employed in refractory edema. Then, it is also used as an adjuvant with that of the thiazide during the therapy of hypertension. Here, the thiazide produces hypokalemia. So, it is used as adjuvant to thiazide to prevent the hypokalemia. It may slightly add to their antihypertensive action. More importantly, it may have the potential to attenuate hypertension related renal fibrosis and ventricular or vascular hypertrophy. Further, it is also used in case of the congestive heart failure. In CHF as additional drug to conventional therapy in moderate to severe CHF can retard the disease progression and lower the mortality. Then, let us discuss the therapeutic uses of the inhibitors of renal epithelial sodium channels, that is the amiloride and the triamterene. These both the drugs shows their inhibition of the renal epithelial sodium channels as we discussed earlier. It is used in the conjunction with that of the other diuretics like the high ceiling diuretics and the medium efficacy diuretics. It is also used with that of the other diuretics to prevent the hypokalemia, and it increases the natriuretic responses. Actually, both triamterene and amiloride are used in conjunction with the thiazide type or high ceiling diuretics to prevent the hypokalemia and slight augment the natriuretic response. The antihypertensive action of thiazide is also supplemented, but the risk of hypokalemia is the most important adverse effect of amiloride and triamterene. These drugs should not be given with the potassium supplements because it is dangerous. Hypokalemia may develop. Hypokalemia is also more likely in the patients who are receiving the angiotensin converting enzyme inhibitors, beta blockers, non-steroidal anti-inflammatory drugs, and in those with the renal impairment. Now, let us discuss about the interactions and the adverse drug reactions of aldosterone antagonist, that is the spironolactone. So let us discuss the interactions one by one. It produces the dangerous hypokalemia if we will use with that of the potassium supplements. With the aspirin, decreases the potency of spironolactone. With the AC inhibitors and angiotensin receptor blockers, produces the pronounced hyperkalemia. Then, with that of the digoxin, it increases the level of plasma digoxin. Now, let us discuss the adverse effect one by one. It produces hypokalemia, as already we know. It produces the adverse effect like drowsiness, mental confusion, ataxia, epigastric discomfort, and loose motions. Also shows gynecomastia, erectile dysfunction, and loss of the libido. Further, in addition to this, it shows the adverse effect like breast tenderness, menstrual irregularities. And as already we discussed in the previous slide, shows adverse effect acidosis in the serotypes. Further, it is contraindicated in peptic ulcer patient where it may aggravate the ulcers. Then let us discuss the adverse effects of the inhibitors of renal epithelial sodium channels, that is the amiloride. The adverse effect is the hyperkalemia. It may be due to the use of this amiloride with that of the potassium supplements. So should not be given with the potassium supplements. May be more likely in the patient who are receiving the angiotensin converting enzyme inhibitors or angiotensin receptor blockers, beta blockers, and the non-steroidal anti-inflammatory drugs. In addition to this hypokalemia also more likely in the patient with the renal impairments. Then the elevated plasma digoxin level is the another adverse effect. Further, the inhibitors of renal epithelial sodium channel blockers, amiloride, may show the adverse effect nausea, dizziness, muscle cramp, rise in the blood urea. It may impair the glucose tolerance. And then the another class of diuretics is the osmotic diuretics, that is the mannitol. This mannitol is a non-electrolyte of low molecular weight, that is 182, and it is pharmacologically inert. Can be given in large quantities sufficient to raise osmolarity of plasma and tubular fluid. It is mainly metabolized in the body, freely filtered at glomerulus and undergoes limited reabsorption. Therefore, excellently suitable to use as osmotic diuretics. The mannitol appears to limit tubular water and electrolyte reabsorption in a variety of ways. So, in the four ways it is showing its mechanism. First, by retains the water isoosmotically in the proximal tubule, where it dilutes the luminal fluid which opposes the sodium chloride reabsorption. The second one is it inhibits the transport process in the thick ascending loop of the Henle's by an unknown mechanism. Quantitatively, this appears to be the largest contributor to the diuresis. Then the third mechanism is it expands the extracellular fluid volume because it does not enter the cells. So mannitol draws the water from the intracellular compartment, so increases the glomerular filtration rate and inhibits the renin release. And the fourth one is increased renal blood flow, especially to the medulla. Here, medullary hypotonicity is reduced, which is due to washing off. So, corticomedullary osmotic gradient is dissipated. So, passive salt reabsorption is reduced. Further, it increases the urinary output, excretion of all cations and anions also enhanced. And it is never used orally because mannitol is not absorbed orally, so has been given IV as 10 to 20% solution, and it is excreted with a half-life of 0.5 to 1.5 hour. Now, let us discuss the contraindication, use and the adverse effects of the mannitol. Let us start with the uses. It is used to increase the intracranial and intraocular tension. It is used to maintain glomerular filtration rate and urine flow in the impeding acute renal failure, but prognostic benefit is not proven. Also, to counteract the low osmolarity of the plasma and then the extracellular fluid. Now, come to its contraindications. Shows acute tubular necrosis, anuria, pulmonary edema, acute left ventricular failure, cardiac heart failure, cerebral hemorrhage. Then the side effect of mannitol is the headache, nausea, vomiting, hypersensitivity reactions. So that's the end of this topic, diuretics. Revise the topic from the book. Have a nice day and thank you.